For the cath lab people, we need to know the names of the roads that we work on, the highway that we travel. And for you vascular folks, this is your business out here in the periphery looking at everything. And for the echo guys, you'll get out there a little bit once in a while, but this is primarily cath lab driving highways and vascular working zone. So at any rate, so what's the difference between vascular smooth muscle and cardiac? How do they contract? We kind of know some of this already. There's a thing called a myogenic mechanism where the body's trying to maintain a steady flow. And then we'll take a look at intrinsic versus extrinsic flow, where intrinsic is local and extrinsic is neural. And then we've already talked about baro and chemoreceptors in other chapters, so really nothing new there. I started thinking about the book last night when I was reading. I thought, why do they have to keep bringing that up in 3 or 4 chapters? Let's just get it done and move on. But so we'll hit that again, and then I already talked about the anatomy. So this is peripheral vascular. Thinking forward, next week we do cardiac output and how the blood moves or how the body regulates the total body. This is going to be looking at more like regional areas. And then the next week is coronary anatomy, cardiac arteries, and cardiac veins, which you usually don't talk about. And the very last chapter in this class is special circulations. And on special circulations, I'm going to be out of town at a conference, so I'm going to have you guys just watch the video on that, and then you'll take the test. And the test on that last one, I already told you this, but it's one question, but it's worth 20 points. It says, I watched the video, so make sure you click yes. Anyway, and then there's a final on the last Thursday of the quarter if anybody needs it or wants it. So we're moving right along with this class. So there's a cross section of a vessel, the endothelium, the media, the adventitia. Maybe around here somewhere, which if we think back to last week in the lymphatic system, there's probably, when you look at the conduits of vessels that go through the body, you usually have nerve, artery, vein, and lymph kind of running together in a conduit. And we kind of learned that in our vascular access for the invasive group. But so somewhere around this artery, there's going to be a vein. It's probably collapsed a little bit. It's not under a lot of pressure. There's probably a nerve. And then there's a very collapsed lymph duct somewhere, probably, usually along the big canals, the big conduits. The smooth muscle is made for resistance. One thing about peripheral vasculature, it has no sodium channel. So there's no real fast contraction like there is in cardiac, that snap of the QRS. It's slow and it's strong, and it's managed by primarily the sympathetic nervous system, not so much parasympathetic, mostly sympathetic. And this is a closer look down at the cellular wall and the sodium-potassium pump that resets the contraction state. Dr. Leimgruber talked about that. Calcium's involved, sodium's involved, potassium's involved. There's a sarcoplasmic reticulum in these cells. That's what stores the calcium. There's calcium channels. Kind of the same as cardiac cells, except no fast sodium channels. These are the chemicals that would affect the contractile state of vascular smooth muscle. And that would be catecholamines like epinephrine, norepinephrine, dopamine. All of these are constrictors until we get down to here. So histamine and angiotensin. In special circulations, the video will go over remember we learned about ACE inhibitors in our pharmacology class in the fall? Angiotensin is a really powerful vasoconstrictor, and the lungs produce something and the liver produces something, and they get together and they make angiotensin, and we block that ACE inhibitor with that drug. So that's one way to block the peripheral constriction of blood vessels, which is hypertension. So ACE inhibitors work in the periphery. So angiotensin will come up in special circulations with angiotensin converting enzymes, and I'll talk about that in the video when you get there in June. Things that dilate are prostaglandins, Serotonin's kind of not so powerful, but adenosine, we've learned, I think we've talked about adenosine before. That's a vasodilator. Prostaglandins have a use in pediatric medicine. When a kid is born with a shunt that he needs to have to stay alive, so if they don't have good communication between the left and right side of the heart, sometimes we want to keep like their PDA open, patent ductus arteriosus. So we give them prostaglandins. That's a vasodilator. It keeps that open, help keep them alive. This is kind of probably of the new things we learned in this chapter about peripheral vascular control. This might be the message. The rest of it to me was kind of review. So this is something called the myogenic mechanism. This graph displays how your body's trying to maintain a steady flow. And here it says muscle flow, and this says perfusion pressure. And this is the closed dots are before the when the condition is, here's the condition, and then your body makes it makes a compromise to maintain steady flow. So look at this flow, milliliters per minute per 100 grams of muscle or tissue. And so it's called a myogenic mechanism, and it's the sensing is within the pressure sensors in the walls of the vessel. And so if I have really low perfusion pressure, and what is perfusion pressure? What is, I said it like a statement, but I'm going to turn the end with a little more. What is perfusion pressure? So that's a question now to you all. What is perfusion pressure? What does that mean?
Your blood pressure?
Okay, it's part of it's your blood pressure. Blood pressure you think of on the way in. So there's another part of perfusion pressure. So if you say your aortic your arm pressure is 120 systolic, that's part of the perfusion pressure. That's the pressure in. Think of Poussillier's law. What's in the numerator? Pressure in is part of perfusion pressure. I'll walk you to it.
Is it about resistance?
It kind of is, but it's really the difference between the pressure in and the pressure out across the system. That's the perfusion pressure.
So your pulse pressure?
It's kind of like your pulse pressure, but not so much. So, like if you think about the systemic vascular system, it kind of gets back to what our resistance part. The pressure into your systemic system is the aorta, and pressure out is the right atrium. That's what's on both sides of the capillaries of your systemic. And in your lungs, it's the pulmonary artery and the pulmonary vein on both sides of the capillaries. That's the perfusion pressure across those beds. So just what's the gradient from one side to the other? The gradient, the perfusion pressure. So back to now that we've defined the terms, back to how your body manages flow. So it wants to maintain steady flow under a wide range of pressures. Look here, from low of 20 millimeters of mercury across the bed to way up to 180. So if you have really low pressure and it wants more flow, this is not something you have to memorize. Just think about it. It just relaxes the vessels and it opens them up and lets more flow go through. Okay, so this is responding to maintain flow, nutrient flow to the tissues. On the other side, if we have really high perfusion pressure, we're going to get a lot of flow and the body doesn't need that much. So it'll cause vasoconstriction and that'll bring down the rate of flow. It's not a flat curve because it's not a perfect system, but it can maintain a fairly steady flow rate over a wide range of pressures between 2 and 4 over this wide, 160 millimeter range of pressure. So that's called a myogenic mechanism. And it happens from the sympathetic nervous system. It's a intrinsic control. It's a local. It's sensing the pressure in the wall of the vessel, and it's either constricting if it's low pressure, or dilating if it's low pressure, or constricting if it's high pressure to maintain steady flow. So that's the myogenic mechanism. Now, this is starting to look at, and that's also called autoregulation. Oh, yeah, I had that on there. Okay, very good. Autoregulation, regulating automatically. And this is independent. This myogenic mechanism is independent of your endothelium. So the endothelium does not play a role in this pressure sensing. And this is showing This is a different example of the myogenic mechanism where it says if I keep raising the pressure, then the diameter, the pressure's rising, 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 and then the diameter is getting smaller and smaller and smaller, which is kind of shown over here, the constriction. Okay, so this graph just shows us really what's happening on this end of this myogenic mechanism, this flow control curve. So I took some time yesterday in my kitchen and really stopped and I really read these graphs very carefully to understand exactly what they're trying to show us, because usually in this book, the graphs will explain about a page of text, all in if you can kind of digest it. And here it shows how they did that. They take a piece of artery and then they have it in a control situation, and then they're changing the pressure and watching what happens to the vessel diameter. Now, in this case, they let's see, transmural pressure, independent endothelium. So here, this one, they had a condition where they strip the endothelium off. They go in there with like a little rake and just scrape the endothelium off, scrape off that inner layer. And so here it shows endothelium intact in dark, endothelium removed in open, and this myogenic mechanism still happened. This is like this, the diameter dropping with pressure rising. Here's pressure rising, and here's diameter. So this is just showing us the same thing, but now it's with and without endothelium. So the vessel still constricts even without endothelium. So that's basically proving to us that the endothelium does not play a role in the myogenic mechanism. It's the pressure sensors in the wall, in the media, in the muscle. And this is just a control. This triangle is showing us what happens when we give nitroprusside, which is a nitroglycerin derivative vasodilator. It dilates no matter what. Okay, any questions about that? Okay. The next slide is saying, well, let's take a look at endothelium again. And so endothelium doesn't respond to pressure changes, but it does respond to flow changes. So like pressure would be the pressure in the wall, pressure sensors, but flow would be like friction along the edge, if you rub your hands together, they get warm. That's flow, that's shear stress, which we learned in hemodynamics, our very first chapter in this class. And this shows flow changing. Here's pressure gradient, essentially, which would mean more flow. Endothelium intact. There's a diameter increase. So with higher flow, the vessel with the endothelium wants to dilate, which is opposite of the myogenic mechanism, isn't it? Let's back up 2 slides. Oops, back up. I say back up. High pressure gradient causing vasoconstriction, right? High pressure. Now constriction, come forward, here we go. High pressure over here, high pressure gradient, this is dilation. So it's the opposite. So let's think, why would that be? Is that a conundrum? Does that make sense? Does that make sense to you? Well, the body's trying to maintain steady flow. So if you have high velocity, it'll dilate and that'll slow things down and keep things in normal range. The body likes things to be in a happy medium. It almost always wants to go back towards equilibrium. If you're cold, you shiver because your muscles will make more heat and warm you up. If you're hot, you sweat, so the condensation or the evaporation can cool you down. So your body likes to stay in a fairly narrow range of temperatures and all conditions, all measurements. Okay, so myogenic is pressure. High pressure gradient causes vasoconstriction. The endothelium is sensitive to flow. High flow rates causes vasodilation. Right there. And that's it. Those are kind of 2 new things we're learning in this section. And now this is more about the tissue flow is regular. This is local metabolic mechanism. So this is to say out in the periphery, not controlled by the brain. Tissue flow is regulated locally by the needs of the tissue. So we knew this from before, but low oxygen will release vasodilators and increase flow. The brain would override it to take its own needs in its own control over the needs of the body. Okay? Now, this is something called active hyperemia and reactive hyperemia. These are two new terms for you guys. When we exercise, if you start lifting weights with your left arm pumps up. More blood goes there. It's the low oxygen, which we just looked at here. Low oxygen leads to vasodilators and increased flow. You start exercising, it's using up the oxygen. And where are these oxygen sensors? They're actually in the venules on the other side of the capillary, and that's where you think you'd want to be sensing that, not on the way in, because on the way in is good blood. So the sensors are on after the capillaries, after the gas exchange, in the venules. I don't know if it said it in the book, but I heard that in a different source somewhere. At any rate, so we're talking about hyperemia. Hyperemia, what is hyperemia? Hyperemia, what does that sound like to you? Just that term, what does that mean? Sometimes you start reading this, I'm gonna like, what's this reaction? And you're like, I'm just memorizing it. No, just really try to understand the terms, and then you're not memorizing, you're just rationalizing. Then you've really learned it. Instead of just, I memorized it for the test, I regurgitated it on Thursday, and I purged on Friday, and I go back to my normal routine. Don't do that. You want to kind of put layers on, paint the layers into your picture and your knowledge of the cardiovascular. Hyperemia. So what does that mean? You can break it down. Someone wants to take the easy part. What's hyper? More. And flow, more flow, hyperemia. So if you lift a lot of weights with your left arm, your arm pumps up. That's active hyperemia. There's a need in the tissue, so more flow is going there. This graph shows blood pressure in an arm, and it says the femoral blood flow. They occlude the vessel for a period of time, and then they release it. And after they release it, there's an increased flow after the occlusion, and that's called reactive hyperemia. So if you occlude flow down a vessel for a period of time and release it, there'll be an increased surge of blood to kind of flush out the buildup of toxins. That's called reactive hyperemia. There's something that happens with heart attacks. It doesn't talk about it in the book, but I'm going to give you a practical application. So if you lose a coronary, and this could happen in any vessel system, it's reactive hyperemia, but it'll happen in your heart too. You lose an LAD for 2 hours until they get to the cath lab and we open it with a stent. As soon as we open it, the body wants to flush all those toxins out. There's a lot of built up oxygen-free radicals. And as soon as we open that artery, there's a huge flush going through a bunch of really irritated tissue. It hasn't been getting any flow. It's toxic, and some of it's dying, and there's exploded blood cells and troponin complex swirling around in the soup. There's all kinds of devastation in the cellular level, and pHs are all acidic. We get the reactive hyperemia, but we often get an arrhythmia as soon as we reperfuse an occluded artery. Did I talk to you guys in the heart attack class about something called reperfusion arrhythmia? It's like the thanks we get for opening up somebody's coronary. We're in there, it's 2 in the morning, we push our wire across the clot, and they go into VFib. Thanks a lot. We give you a fresh drink of water and you puke. And now we got to shock you. So that's something that happens in the heart. We get reperfusion arrhythmias, but it's also part of this reactive hyperemia, flushing out all the detritus. The longer you occlude it, the longer the reactive hyperemia happens. That's what this is showing us. Okay, any questions about that? This graph doesn't really show it very good, but active hyperemia is just more flow when you're exercising. Active. Reactive is reacting to an occlusion. Maybe that helps you remember. Capacitance and resistance vessels. Well, we learned about capacitance last week when we talked about pulse pressures and volume changes. Big volume change will cause increased pulse pressure. Capacitance versus resistance. Well, usually the arteries are the resistance vessels, and they think of the veins as capacitance vessels. So our arteries can help regulate flow, and the veins are more like storage. The blood kind of parks there and rests there when you're not really exercising. When you start exercising, the blood actually gets recruited from the venous system over to the arterial. The capacitance storage area unloads its volume over to where it's needed. That'll be addressed more next chapter. But that's really all there is. That's it. The vessels can regulate flow by resistance. The veins are storage area. Remember we had the very first chapter, it showed like 80% of our blood was in the veins and 20% was in the artery. That was at rest. That'll change with exercise. Okay. Pretty straightforward. This is controlled by sympathetic stimulation. And these are the sympathetic innervations to the vascular system. Here's the carotid artery, the bulb of the carotid artery, and the baroreceptors are there. If you scratch your neck, you could cause bradycardia because you're tricking these baroreceptors into thinking they're being stimulated. If you take a deep breath and bear down, feel your heart rate, it will drop. Have I had you do that in class before, where you do a Valsalva and feel your heart rate go down like from 60 to 40? That's the baroreceptors saying, hey, I'm feeling pressure. I'm protecting my brain. I'm going to slow down that heart rate. Okay. If we tickle this with a wire, if we're trying to go up into your brain to do a stent in a plaque up in your cerebral circulation, we tickle this bulb with a wire, they can go into profound bradycardia because we just bumped right on that sensor with a hard piece of metal. And we really get like heart rate of 20. So when we're doing carotid work, we keep a drug around that can bring your heart rate up real quick. What's that drug? It's vagolytic. It knocks out your vagus.
Atropine?
That's atropine. We keep atropine around. We always have a bucket of atropine in the cath lab for bradycardia. We have a bucket of epinephrine around for hypotension. Those are some of we keep that around. We know those drugs work, so we use them. Once you guys get in the hospital and see these drugs being used, then they'll make more sense to you. Like, God, this guy's got bradycardia. We give a 0.5 milligram of atropine. Now he's got a heart rate of 70. Wow, that really works. Then it makes more sense. Sarah had a question.
So is it pretty common to accidentally bump into those baroreceptors?
Yeah, because we're banging along with our wire. So whenever we're heading north along that highway, we're ready for bradycardia. Even around the arch of the aorta, you can get bradycardia because there's baroreceptors in the arch of the aorta. But these ones right here, so there's baroreceptors in the aorta and baroreceptors in the carotid bulb. The ones in the carotid bulb are a lot more sensitive. So if you bump into them, yeah, you're going to get bradycardia. If you start tickling, you start massaging your neck, you'll probably end up with bradycardia. Okay, enough about that. This is the firing of the sinus node, these carotid sinus nodes. And if there's high pressure, there are, well, let's see here. It says sensitive, the carotid sinus firing. So it's trying to slow you down. Sensitive to high pressure, see blood pressure 200. Well, if you have a high pressure, it's like bang, 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 alarms, slow it down, slow it down. As the pressure starts dropping, it's not going to be very active. And it's only active when the pressure is rising. Like, hey, I don't like that pressure rising. Let's slow it down. Oh, the pressure's falling. Turn off the brakes. I don't need the brakes. My pressure's falling. Stop the brakes. Okay, that's what that is. This is something that's kind of interesting. It says that your carotid baroreceptor is sensitive to pulse changes. It likes to see a rhythmic change if that's what it's used to. If you give it a damped pressure, like what you would have after stenosis, if you have a carotid stenosis, downstream from that, the pressure is blunted and damped. Like on aortic stenosis, we have pulsus tardus, pulsus parvus, a slow upstroke, and a damped aortic signal. Well, the carotid baroreceptors, they don't like that. If they see that, they say, hey, man, something's not right. I need more pressure. And they'll respond to that. And that's all this is showing. So here, if we damp the pressure, then the inhibition is diminished and the pressure rises for that period. When we let the phasic signal come back, then the pressure comes back down. So that's one way your brain can, if you have carotid stenosis, your brain can elevate the pressure to get more pressure past that stenosis to feed it what it wants. That's interesting. I wouldn't have thought it would be sensitive to rhythmic pressure changes. I wouldn't have figured that one, but it is, and this graph is their demonstration of it. Okay. Now this is switching from baroreceptors to chemoreceptors. So back to my theme of the day, defining our terms. What is chemoreceptor? Chemicals. And the chemicals we're working with are like oxygen, CO2, pH. Yeah, pH is the acidity. Okay. So this is really more about, this is talking about the vessel, but we already learned in our, remember that regulation of the heartbeat chapter with all the 10 things that can make it go up and down? We learned that a little bit of change in these chemicals will make, you'll get a stimulation, but big changes, you get depression, remember that? Well, this is showing, this graph shows the arterial pressure, so they keep it constant for this example. And now they're not messing with pressure. So they're showing you the pressure is constant. And here's the window of time they're manipulating the chemicals. And what they're doing here is, here I wrote it down, because first when I saw it, I said, oh, what is that graph? And I was like, I don't know. I mean, what do those things mean? So I had to go read. I had to read yesterday, for God's sakes, which is good. Read the book, learn more. The PI, did anybody read that? Did anybody like me? Like, what is this PI? Anybody? I'm supposed to be leading this, so I'm supposed to know. But I'm just going to let you guys stew on that for a minute. I had a class my very first year. I was teaching shunts, and I didn't do my prep work, and I didn't know what all these things were. And I'm up here talking, and then students started asking me questions, and I didn't know the answers, and I had a flame out, total flame out. Like, anybody? I throw it. The first response when you're speaking, if you don't know the answer, you throw it back to the group. Kind of like, what's that show on TV where they have lifeliners in the audience poll? Usually the audience knows, but I had no help. I had no lifelines. So I told them, I said, hey man, I just can't do it. I don't know. I'm embarrassed, but we're just gonna have to end this discussion, and I'll go read up tonight and we'll come back to this next time. But that's not happening today. So you've had enough time now. What is PI? I gave you some time to think. Okay, well, this is your body's, we already said these, we're looking at chemical changes, and we said that big changes in chemistry would cause vasoconstriction. That's what this says with the baroreceptors. But what this graph is showing us pulse interval, and 500 milliseconds is meaning a heart rate of 120, and 1,000 milliseconds would mean a heart rate of 1, because 1,000 milliseconds is 1. So pulse intervals, how much time between heartbeats? So it's saying if you really wipe out you really manipulate these chemicals, you'll get profound bradycardia. And we already knew that from our heart rate chapter. That's all that's showing you. And this is VT. Does anybody know what that is? I won't punish you too much more, because maybe nobody really dug in and found out what all these variables were. But that's the tidal volume. How deep is my breathing? So if you have hypoxia, your lungs will take deeper breaths to flush and get you back to normal. That's all that's showing us. Nothing really new there. Just an exercise in paying attention to what's on the graph. These are all the wirings of your brain to all of your body's inputs, and it's talking about intrinsic versus extrinsic control. And intrinsic is local, and extrinsic is brain. So at rest, your brain controls all the flow to everything. But when you're exercising, it makes sense. Little areas like left arm working, left arm needs more flow. Local takes over. That's all that is. I could read the rest of that, but you can read it too. So the arterioles constrict in response to brain and chemical factors. They don't have the smooth muscle cells in your vascular system. They are, remember we said we had alpha, we had beta and alpha sensory sites, and the heart was beta. Do you guys remember from our fall class for chemistry what receptor sites for the sympathetic nervous system innervate the smooth muscles? It wasn't really in the book, but it was in our pharm class. Then we have alpha and beta. They're alpha receptors in these vascular smooths. So they pretty much turn on. and they don't turn on fast, they turn on slow, but when you turn them on, they hold for a long time. Unlike cardiac, which is twitch. Well, skeletal is twitch, and cardiac is rhythmic, strong and quick. The smooth muscles are not like skeletal, which is fast twitch, and not cardiac, which is fast and rhythmic. It's slow and strong to hold pressure, to regulate flow to an area for a long period of time. Kind of makes sense. The myogenic mechanism was discussed, so you'd want to be able to, I'm going to ask you, what is the myogenic mechanism and what happens with high pressure and what happens with low pressure? You'll tell me. With low pressure, we want more flow, so we vasodilate. With high pressure, we don't want so much flow, so we constrict. That's myogenic mechanism. Auto-regulation. And the little sensors in the veins will know if that organ system is really using a lot of oxygen. The venous system the little sensors will know, and it'll vasodilate to let more flow go through that area if you get a bunch of CO2 down there or low oxygen. Neural control is based on sympathetic. We talked about that. At rest, local. Neural's taking over at rest, like this picture. It's auto-regulation, but when you exercise, it's local. And then we already talked about those. So we'll move to these angiograms, or these. We are at 9 o'clock. We are halfway through the class, a little bit more than halfway through. Now we're going to talk about gross anatomy, not in the book, but important for us to know because that's where we do our work. Okay, so this is a picture of an aortic arch. And these are standard when we do an angiogram of your head, sometimes we call it a 4-vessel study. We're doing if we're taking a picture of your arch, we'll call it an aortic arch. But if we're going further up into the brain, we'll call it a 4-vessel study, and that being the 2 carotids and the 2 vertebrals, 4 main vessels that feed the brain. So this over here, this is the heart, and so flow's going this way. This is the ascending thoracic aorta, the descending thoracic aorta. That's not on the labels, but that is what this is. This is the aortic arch. And this goes from anterior in your chest. Let's see if you guys can still see me on video. Anterior, and the descending aorta is diving posterior along your spine. So it comes from anterior, and it goes from anterior from right to left, and goes back down posterior along your spine. It's anterior. So if you looked at it from the sideways, you'd see, if you looked at it from lateral, you'd see your arch look like this, because that would be it. When we actually want to look at your arch, it kind of goes at about a 45-degree angle. So when we want it goes anterior from the right, posterior to the left, and then down the left side of your aorta. Excuse me, down the left side of your spine. Your inferior vena cava goes down the right side of your spine. If I want to look, and so the angle of my aortic root is like this little. I don't have anything else that's shaped like that. Okay, this is how your aorta. So if we want to see it, we need to be over an LAO 45 degrees, and then we get a nice perpendicular look at your aorta. That's our best pictures, looking at it straight on. Not at an angle, but straight on. So that's 45 LAO, if you wanted to know. Okay, so what is this? That's the innominate. First one up. Now there's variations in this. There's variations in the aorta, and the vascular guys could talk to us for half an hour about the variations of the aortic arch, but we aren't going to do that today. We're just going to leave that for another discussion. But this is the innominate. Or also called the innominate, or the brachiocephalic. Yes, brachiocephalic, because part of it feeds the brain cephalic and part of it feeds the arm brachio. So that's the brachiocephalic or innominate. This would be number 3s are common carotids. And number 5s are subclavians. These are going to go out and feed your arm. They will drop down internal mammary arteries right here, and they'll drop little scapular arteries right here. If you take a picture of those, they look like a little triangle. The scapula is kind of a triangle, a scapular artery. They'll go out here to your arm, and we'll get to the arm later. But let's keep looking as we go. So innominate goes to the right. Now, when you're doing these, you have to say left or right. So you need to label it. Was that beat into you guys in the vascular pretty good? Make sure you put left or right. For us, the LAD, circ, and right, we don't have to because there's only one of each. But you guys have to say left or right because there's two. So this is it's like they're looking at us, the right subclavian, the left subclavian. This is the left common carotid. Now there's a bifurcation. The one that has the bulb is the internal, and the one that doesn't have that doesn't have the bulb is the external. We'll look at that with a real angiogram a little bit later, and I'll show you some more ways to figure that one out. If you hear, you can't really tell where they're going. One kind of goes up to the face and one goes into the brain. We'll look at that a little bit later, which is right now. This is just a very little bit later. This is the common carotid. There's the bulb. And there's one branch that has all these swirlies. This is the jaw. There's the face. There's your cheek. And this one's heading up to feed the brain. So the one that's feeding the brain is the internal carotid. The one that's feeding the face with all the squirrely side branches is the external. We rarely do anything with the external in our work. Ischemia to the brain causes problems. That's what we end up getting involved with. This guy has a really bad lesion. Look at that. It's an eccentric lesion. It's on one side. It has about an obstruction of about, say, 60%. So 40% of it's open, but we would call that as a 60% eccentric stenosis in the proximal internal carotid artery. And we probably would want to go and put a stent in there. Or they could go cut them open and peel that plaque out, and that's called an endarterectomy surgery. And those are good too. That's a good way to fix that. Just peel that plaque right out of there. Or put a stent in. Okay. Now let's look at the arteries down the arm. So coming from the innominate, we had the right internal, well, here we go, backing up. We had the right vertebral, the right common carotid. So here, this doesn't show these very well, but there's the right innominate, right subclavian. So we're going to keep coming. There's the clavicle. There's a bone landmark right there. Coming down the arm, there's the axillary. Here, what does this show? Oh, they all got shifted. Well, let's see if I can shift them all. Oops. Oh, let's not play with that. I think I will play with that just for a moment, see if I can fix it. Oh, I have to do them all one at a time. I put them all in there one at a time, I guess. Yeah, I'll fix it. Yours might be fixed on your print. Was your print copy okay?
Yeah, mine's good.
Well, I don't know how this got screwed up. Must have done something. I must have done something when I was teaching it and I didn't save it or something. Okay, so that's better. So now we'll go play. So there's the right subclavian. And then as I come down the right axillary, you can feel that pulse under your arm. And then brachial comes down to about here. It's your elbow. And then you have a bifurcation. Over here would be the thumb. This is the anatomical position, like the Vitruvian man. He's standing like this with his arms out like. Oh, the camera's way over there today. Okay, that's the Vitruvian man like that, arms out. So let's do camera. We'll go preset. Somebody, who was teaching last time is a walker, and that would have been Tina. She's a walker, right? She paces the whole front gallery. Now, there we go. That's me. I'm more of a podium guy. There, hey, all right. So, brachial. You can feel the brachial pulse. If I come down to the wrist by the thumb side, that is the radial right here. And if I go down by your pinky side, that's your ulnar. Then down further, there's a palmar arch where they connect. And then there's little digital arteries that feed each finger. When we're doing our cath procedures, a lot of times we go in your radial artery. That's a new thing we do, because now we don't make people lay down in bed. And if we poke them in the leg, they got to lay in bed for 6 hours. We just put them in the arm. They can sit up right away. It won't hurt their back. But we have to make sure that they have good flow to the ulnar artery in case we screw up the radial artery. So what do we do to make sure, it's a little simple bedside test, what do we do to make sure their ulnar arteries able to feed the hand if I lose the radial? It's an Allen test. We want a negative Allen test. Yep. Very good. You guys in echo and vascular know what the Allen test is?
Yeah, we've been over it.
Yeah, okay. We occlude, we pump, we release. If it perfuses within 10 seconds, it's adequate to keep the hand alive. We did a case, we did a procedure from the arm in a patient in Seattle once. We actually went in the brachial. We surgically went down to Soane's procedure down in the brachial artery, did a heart cath, sewed it back up, and the clot got down in her hand. Might have told the invasive guys, but then she couldn't use her hand. Her hand was numb and it was weak and she couldn't use it. That's not good, but it was even worse because she was like first chair Seattle Symphony violinist. That's not good. We knocked out the top chair, and that was her livelihood and her life and her passion. So that was a major catastrophe for her. And I never found out what happened. I think they probably did some vascular, they did some streptokinase to dissolve it, and they might have had to go in and suck out the clot. But I think they got her hand back. But that was catastrophic for any of us, but especially for first chair symphony violinist. I found this really cool little show on Mozart of the Jungle. It's like about the New York Symphony. It was on like Prime Video. I've been digging into that. You stumble onto these, got a little time on your hands. You guys have very little time on your hands, but I have a little bit more. I was watching all these competitions between all these chairs, very stiff competition at the symphony. That's where it's called the jungle, I think. Anyway, there's the any questions about the arm flow? Nope. Next, leg. So we're going to go from the distal aorta all the way down towards the feet. So here's your distal abdominal aorta. Then you have the bifurcation, and then we have the right common iliac, and then the right external and right internal iliac. And then here's the inguinal crease, and down here's the common femoral. This is where we might go in with our cath lab procedures. And this is the profunda, superficial femoral, also known as, and we don't want to go in that one. This is the superficial femoral artery, very long, and goes down your thigh, right along the femur. There's a lot of this. Weirdly, a lot of disease gets deposited in these leg arteries, but it's weird. I don't know why, and maybe you vascular guys, nobody's told us yet. We rarely have atherosclerosis in the arteries of the arm. But we very commonly have atherosclerosis in the carotids, coronaries, renals, and inferior circulation, but not of the arms. So what is it about the arms that keeps them from getting a bunch of plaque? We just don't have it. You guys don't know that yet. You just have to believe me. But it's true. So does anybody have any rationale for what keeps the arms protected? I don't know. If you can figure that out and apply it to the other systems, you could retire today on your own Caribbean island, served by your own jet with your own private airport, or your helicopter coming off your yacht. Whatever, you'd have it made in the shade. Okay, so we keep going. So we were at the superficial femoral. We get down to the knee. That's popliteal. Okay, that's popliteal. Now we can do some work down there, but the surgeons, that's really hard for the surgeons to do vascular surgery in the popliteal area. It's inside this little adductor canal, and it's really hard for them to get in there. So working on the popliteal is kind of tricky for surgeons. We can get in there, but it's so flexible because it's under your knee that it's a hostile environment for any like stents that we put in because they're going to get bent and flexed a lot. So it's actually, if you have a problem in your popliteal, it's kind of hard for us to fix. The other ones we can fix anywhere else, but that one's a tricky spot. So then I go down here to the anterior tibial. Now this is going to run all the way down to your foot, and that's going to become the dorsalis pedis, the one you feel next to your great toe, the tendon of your great toe. And then this is the tibial peroneal trunk, and then this one's a peroneal artery, and this one feeds like your calf muscle for walking upstairs. And this one is this is the anterior tibial, this is the posterior tibial. And this goes right down behind your ankle, becoming the posterior tibial pulse. Two of the pulses we feel when we check your peripheral pulses are dorsalis pedis off the anterior tibial, and then posterior tibial directly behind the ankle. Okay? Let's see. Any questions about any of that? Okay. This one's the internal iliac. We don't usually do too much work there, but I'll just tell you, I was at a conference in it was either San Francisco or New Orleans a couple of years ago, and this doctor was doing this procedural discussion about angioplasty on the pudendal artery. Pudendal. Anybody in vascular or anybody know what the pudendal artery is? So this has to do with these patients, they don't have good flow to their groin, to their genitals, and it prevents males from having erections and not having a good sex life, which is part of quality of life for people. And this guy says, hey, I use cardiac size, because it's down to 2 million, I use cardiac size balloons, and if this guy has erectile dysfunction and Viagra didn't help him, so they look, well, what's going on? Is it blood flow? Is it neural? Is it psychological? And they rule these things out. If we take a picture, when we take our pictures, if we just scan down and look at the pudendal, it's got a big plaque. He was putting stents in and giving these guys blood flow down there. And he says, I started this as a side business, and I'm getting all these referrals from all like 5 states, and I'm making lots of people happy. So that's the pudendal artery story, deep down into the internal iliac. Interesting. I just stumbled into this conference presentation. I thought, oh, that looks, it was like a room, and there's room to sit, and sometimes they're so full. And I sat in there, and I thought, what's this all about? And I started listening, and said, so I learned something. Sometimes you just stumble into interesting. It's called serendipity. You stumble onto something interesting. So that's the end of that. Now, we have a couple more minutes. I thought it might be interesting to show you a couple of runoffs. So we look at these in gross anatomy. So I'm going to give you pictures, gross anatomy pictures, and have you rename all these peripheral arteries. So you need to know them inside and out. Make sure you tell me it's left or it's right, because if you don't tell me, then that's not correct. So pay attention to these arteries in the periphery, that they are left or they are right. Okay? So this is taking a while. That's okay. Let's see if I had any other notes that I wrote for myself to tell you guys. No, I didn't even have the pudendal artery story on here. I just remembered that. That just came back to me from deep, deep in the memory banks. The list of stories. The well, it's called the well of stories. There's a lot of depth there. And I have to go for the G stories, G-rated stories here at this location. There's other pools of stories. Adelis doesn't want to hear those. And I don't tell those when I'm up here. I can't tell those here. Okay, let's see. Angio, let's see, peripheral. Let's just see what happens when we do that. Oh, look at that. Let's just see. Now let's do videos. Okay, that's 2 minutes long. That's kind of long, but I'll poke in. No, I don't want that one. Oh, I guess I can. All right. So this is a patient. We're doing an angiogram, and we're looking at only the left side of their leg, and we don't have the right side. Now, that could be because we put a catheter up the left side and we squirted it directly into the right side. We only see the right side. But if I was shooting it from the root, then the right side is totally occluded. See, there's nothing over here. There's the internal iliac, or the external iliac. There's the superficial femoral artery right there. There's a common femoral artery, and actually there's a common femoral right there, because that's the head of the femur. That's down at superficial femoral. There's a profunda. And there's a stenosis of about 60% here between the common femoral and the superficial femoral. So let's see what happens when I do a runoff. So, okay, so here, this is what it looks. Okay, there we go. Oh, hey, oh. All right. That's how it looks when we do it live. Oh, there's a little pigtail catheter. That's what that circle is. There it is. Now here's a pigtail, and this is in the aorta, distal aorta, and now we're going to see what happens. We usually have to chase this. We do what's called bolus chasing, but they didn't do it here. Okay. All right, that's fine. When we take pictures, the blood flows down the legs and it goes outside the picture of our screen. So we have to move the whole table, and we call it bolus chasing. We're panning, moving the table as the contrast flows down the legs. And sometimes it flows down one leg faster than the other. So we can't get both of them at the same time. We have to do two pictures because one leg's normal and it goes fast, and one leg's abnormal, it goes slow, and they are not in the same frame at the same time. So it's a little tricky sometimes. Let's see. I just want a little runoff here. Just 34 seconds. There we go. That'll fit the attention span. Here we go.
Angiography is an imaging technique that is used.
No, it won't. Okay, let me go to images. Let's see. Then I can pick more carefully what I want. There's a good one. So this is good. This is down the leg. Both legs. This is the whole body. We don't usually take pictures like that, but that's what this is. This is the iliacs, superficial femoral, the popliteals, tibio-peroneal trunk right here, peroneal. And then this one is which vessel is it that leads out here to the top of your foot? Which vessel goes out here to the dorsalis pedis? Which one of these guys? One of them goes behind your ankle like this one. That's the posterior tibial. And one of them comes down. The anterior tibial comes down to the dorsalis pedis. So this person has an obstruction here. When we get down towards your feet, sometimes we'll actually poke you from the ankle and work backwards. Instead of trying to come from up here and come all the way down, we will come in close and work backwards. Yeah, okay. See what else we got. Here's some popliteal disease. So there's the knee joint. So there's that adductor canal. Well, the surgeons, they like to do like grafts, and they don't need to use saphenous grafts or arterial grafts like we do in the body, up in the heart. These vessels are large enough that a man-made graft can be put in, like a Kevlar graft. Put those grafts in and they stay open. So they just spool it off and snip it off and get however many millimeters they want and stitch it in, proximal and distal anastomosis. But they can't really work there in that knee. So that's a bad popliteal right there. That's not good. So they would have claudication. The symptoms of peripheral vascular disease is called claudication, when they have pain when they walk. The nice thing about that is they can stop walking and rest it and the pain will go away. The brain, if it has ischemia, you get TIAs. In the heart, you get chest pain, angina pectoris, and the metabolic activity of the brain does not stop and the heart doesn't stop. But the legs, if you get claudication, you can stop, put your foot up and relax and let it kind of calm down. One thing that's kind of interesting about the periphery, one of the treatments, instead of doing all these surgeries and interventions and drugs, they just tell the patients to go out and walk until you have ischemic pain. And whatever your pain threshold is, walk until it hurts, till you can't take it, then stop. So you keep exposing your body to ischemia over and over. And what does that do to your body? What does it do if it keeps getting ischemic exposure? You get collaterals. So you can build your own bypasses with periphery just by walking. That's the treatment. Go for a walk every day. Buy a dog. Buy a terrier. Or buy a whippet. So you know what those little whippets are? They're like little mini greyhounds. I wanted to get one of those once, but I thought it would be too cold in Spokane to have a whippet. They're just two little skinny little guys. They have no fat on them. But they're called Italian greyhounds. I wanted one, but I didn't get him. All right, what else? Anything else? Any other questions? You guys from vascular, you know, they're teaching you all kinds of stuff in peripheral vascular. I did a lot of vascular interventions in my days in the cath lab. Here she is. She's rubbing her calf. She got claudication in her left leg. One thing that's interesting, if you look at somebody's feet and they have no hair on one foot and hair on the other foot, women always shave all their hair off, so you can't really use this. But guys, if you lose all your hair on one of the legs and the other leg has hair, what is that? What do you think that could mean? What's that all about? Eh?
Low vascular flow.
Yeah, bad vascular flow. It doesn't feed the doesn't feed the grass. Don't get any hair. So that's another weird thing. I remember talking to my dad. He had some peripheral vascular disease. He had some radiation treatment in his pelvis from testicular cancer, and it caused a lot of scarring of his vasculature in his pelvis and led to peripheral vascular disease. So he had no hair on his legs. And I noticed that one day. I said, Dad, what happened? You don't shave your legs, do you? Because we usually have pretty hairy legs in my family. He's like, he has a really hairy, like gorilla chest, and then shiny white legs. And I said, what's going on, Dad? I said, when you walk, does it hurt? He goes, a little bit, so I just don't walk too much. I'm like, that's not a good answer. Hey, Tina, come on in. Anyway.
Are you gonna roll?
No. So he had peripheral vascular disease. We better give him a little break here. So that's it for that class, and that's it for angiograms, and we'll see you next time. We'll
Thank you,
keep just keep the broadcast going for Tacoma because Tina's here. Don't save. Oh yeah, I do want to save because I changed the point arrows. Okay. Nah, I was just telling the story about how my dad didn't have hair on his legs, which meant he had peripheral vascular disease. That was my guess, along with his claudication. And he did. So I found him a good vascular surgeon in Tucson, and they fixed him up.
Perfect.
They fixed his carotids and his iliacs. Yes.
That's what you need.
Switch user.
Thank you.
Yeah, you're getting close, aren't you? I know you're doing their big gowning test yesterday. There's a lot of buzz in the hallway.
Always is. They always kind of like,
That's good.
they go, I'm nervous. I'm like, you should be nervous.
I told him take it serious yesterday. I said, practice 20 times, and you think you got it 20 times more.
That's right. That's why I said the same thing. I said, I'm really worried because they had that Wednesday break, and I'm used to having boom, boom, boom.
Oh,
So they had a whole
continuity,
week. They had a whole
continuity
week.
gap. Huh?
Yeah.
Huh.
I was a little bit worried, but they did well.
See ya after lunch. Remember, John Holmes is coming today from Denver. He'll be here about 1:30, 1:40, as late as 2. He lands at 12:30 in Spokane, so he has to get a rental car to get over there. But you'll be a chance to meet a cardiovascular service line manager, which is good for your career.